תראה, יפה. טוב, אז ברוכות וברוכים השבים, בואו נראה כמה מכם ברחו לאכול או משהו כזה. אוקיי, אני מאוד מאוד מעריכה את זה שאתם נשארים, ותראו שלא תתחרטו על זה, כי ההרצאה הבאה מרתקת וחשובה מאין כמותה. שאלה שחוזרת לאורך כל הכנס הזה היא איך עושים את זה, איך מנטרלים את הפחד, האם צריך להציף את הקהילה במספרים, להוכיח שאחוזי האלימות למשל בקרב מתמודדי הנפש נמוכים מהאלימות הממוצעת בחברה הישראלית, האם צריך להטיף או שמא לקבוע עובדות בשטח, כי גם מי שרוצים את השינוי משני צידי המתרס לא באמת יודעים איך לבצע אותו בפועל. מחקרים וסטטיסטיקות קיימים, אבל אנשי המקצוע אולי חוששים להציג אותם כדי לא להעצים את הסטיגמות. ואנשים עדיין בורחים מלתת למתמודדי נפש לגור לידם, אפילו עכשיו בתקופת הקורונה נבנה הוסטל כמעט בסתר, זה לא פשוט, זה לא קל לשלב, אבל ככה ראוי ונכון לעשות, וזה ישתלם לכולנו. השאלה איך משכנעים שזה מה שנכון לעשות. ועל השאלה הזו, בין היתר, יענו שני המרצים הבכירים שיש לנו הכבוד הגדול לארח אותם כאן. יצחק פרילטנסקי הוא פסיכולוג קליני, דיקן לשעבר של בית הספר לחינוך והתפתחות אנושית באוניברסיטת מיאמי, שם הוא מלמד היום כפרופסור לחינוך ולימודי פסיכולוגיה, הוא מכהן כסגן נשיא לתרבות ממסדית, עוד ועוד תארים שהוא מחזיק בידיו, והוא חי ועבד בישראל, קנדה, אוסטרליה, ארצות הברית, פרסם 12 ספרים, יותר מ-140 מאמרים, ותכף נשמע את משנתו, ולצידו ג'פרי נלסון, פרופסור אמריטוס לפסיכולוגיה באוניברסיטת וילפריד, שם עבד 38 שנים בתוכנית לפסיכולוגיה קהילתית. פרופסור נלסון קיבל את אות מקניל על פריצת דרך בבריאות נפש קהילתית, ואות עבור תרומה ייחודית לתיאוריה ומחקר של הפסיכולוגיה הקהילתית. גם הוא פרסם 12 ספרים, יותר מ-160 מאמרים. רבותיי, thank you for being with us, and it's honor to have you here.
Thank you so much. It's a pleasure being here with you. I just want to make sure that we can all see the slide.
Yeah, we can see it.
Excellent. אז ראשית כל אני רוצה להגיד כמה מילים בעברית. תודה רבה בשם ג'ף נלסון, העמית שלי, ובשמי על ההזמנה להיות איתכם. זה כנס מאוד חשוב. ההרצאות שלנו יהיו באנגלית, אני אשמח לענות על שאלות בעברית גם בסוף, אז אנחנו עם זה יוצאים לדרך. אז אנחנו היום הולכים לדבר על paradigm shift, so now I'm switching to English. So the title of our presentation is a paradigm shift from person-centered to community-centered approaches to psychiatric health and well-being, psychosocial health. So as you can see, we've divided the talk into two parts. First, I will talk about mattering. What are the consequences of mattering or not mattering for mental health? What paradigms inhibit and promote mattering and psychosocial health? And what are countries doing and what countries promote mattering and prevent psychosocial problems? So after I speak for about 15 minutes, Jeff, my colleague, will talk about the principles of transformative change in community mental health. He will offer housing first as an exemplar of transformative change in community mental health and homelessness. And he will offer evidence for the effectiveness of housing first. And he will also address the implications for policy. So let me start by addressing the issue of mattering. All of us have a profound need to matter. When mattering is blocked, our mental health diminishes considerably. People with psychiatric conditions experience a lot of barriers in their quest to experience mattering. Mattering to be clear, is about feeling valued and adding value. We can feel valued by ourselves, that is the self portion of the wheel in orange. We can also feel valued by others at work and in the community. So I'm talking now about the left-hand side of the sphere. Feeling valued is about being appreciated, recognized, respected, and treated with dignity. Adding value, in turn, the right-hand side of the sphere, is about making a contribution to yourself and others, helping people, mastering a skill, developing your strengths, assuming leadership roles in the community. These are all examples of adding value. Now, this has been called contributive justice. It is our right to be able to contribute, which often people with psychiatric conditions are deprived of. Our own research demonstrates that all these individual segments of the wheel of mattering are independent and unique contributors to mattering. In other words, all these segments are really important. People with special needs are no different than the rest of us. They thrive when they feel valued and have an opportunity to add value. However, because of their circumstances, they often struggle to feel like they matter. Now, when people in a community feel that they do matter, that they are valued and they are adding value, they are more likely to experience self-compassion, autonomy, mastery, positive relations, overall and mental well-being, and a number of really important outcomes. This, of course, applies also to people who suffer from psychiatric conditions. In a study we recently conducted in Italy, we found out that people who report higher levels of fairness in their lives, that they're treated with dignity and respect and have access to resources, they report higher levels of mattering, which in turn improve levels of wellness, including physical, psychological, community, and interpersonal wellness. In another study we conducted at the University of Miami with approximately 5,000 of our employees, we found that the more people experience mattering in the university culture, the more they report feeling engaged and included. And these two variables, in turn, predict well-being in multiple domains of life, including physical, community, social, purpose, and overall well-being. The problem is that when mattering is blocked, we end up with all kinds of problems. For example, depression affects 322 million people around the world. Globally, 85% of workers are either not engaged or actively disengaged at work. Around the world, extreme ideologies are on the rise, posing a serious threat to liberal democracies. So let's ask ourselves, what do depression, disengagement, and social disintegration have in common? They all result from lack of mattering. When we feel devalued, there are real psychological, organizational, and political consequences. Some consequences are internal. We get depressed, but some are external. We become aggressive. When the need to matter is thwarted, we feel invisible and helpless, which is a problem that a lot of individuals with psychiatric challenges experience. Now, People with psychiatric conditions often feel like they don't matter because of exclusion, loneliness, disengagement, rejection, and lack of resources. It is our job to reduce the risk factors, the red risk factors on the slide, as you can see, are the ones we want to minimize and eliminate. For example, at the interpersonal level, we want to reduce interpersonal rejection, isolation, and loneliness. At the community level, we want to reduce exclusion and disengagement. At the psychological level, we want to increase positive self-regard, mastery, and self-efficacy. So these are the challenges and the opportunities that we have to increase the sense of feeling valued and opportunities to add value. Now, as we shall see, this is what in many ways Housing First did for thousands of people experiencing psychiatric problems, and Jeff will elaborate on that. Now, I would like to say a few words about the shift from a paradigm of amelioration to one of transformation. So we have to ask ourselves, how do we promote mattering and well-being for people with disabilities and psychiatric conditions? For the last 100 or so years, medical, psychological, political, and educational remedial efforts have concentrated on what I believe are 4 wrong assumptions: that we can improve wellness by pathologizing people, by being reactive and arrogant, and by blaming people for their misfortune. We call this the drain approach because it sucks energy out of people. We overcome these problems when we embrace what we call the SPEC approach, which is based on strengths. I believe there is a little echo. I think we're good now. So it's important to embrace a transformative approach, which is based on strengths, prevention, empowerment, and community change. There is a great deal of research showing that stereotypes and focusing on deficits does not help. They do not promote mattering. On the contrary, they make people feel like they don't matter and don't belong. Research on stereotype threats shows that when minorities or people with disabilities are reminded of some stereotypes pertaining to their group, their performance declines. So unfortunately, in psychology, my profession, as well as in the medical field, there is a problematic history of disempowering patients. So we're going to see next, through Jeff's example and some others I will show, how to overcome these problems. So the 4 principles of the SPEC paradigm can be mapped out in 2 fields. What we're looking at now is what's called the mattering field, which consists of the level of participation of people in programs, in solutions addressing their challenges, and their capabilities. So the more our interventions focus on strengths, the better they are. The more our interventions empower participants, the better they are, as some of the excellent programs that were described earlier in the conference today. It's all about building on strengths and empowering people. Unfortunately, we see a disconnect between where we are today in many societies. We are in quadrant 3, at the intersection of disempowering and deficit-based orientations. Now, as I said before, Jeff will expand on opportunities for strength-based and empowering approaches. Now, here we see the second field, what I call the contextual field, which consists of temporal and ecological dimensions. Temporal has to do we intervene early or late? And ecological dimensions, do we focus on individualistic or collective solutions? And we can see that most of our societal efforts go towards reactive and individualistic approaches, whereas the most promise is found on proactive and collective approaches. Now, in two recent studies on the impact of social justice policies, including accessible healthcare and policies of inclusion, a colleague and I demonstrated that policies of fairness improve mattering in two ways: through the promotion of individual autonomy and social capital. Autonomy, or the ability to add value to yourself and the community, is essential in mattering, as we said. Social capital, in turn, is about feeling valued and adding value through relationships in the community. And as we can see, it's also key to mattering. So it turns out that both autonomy and social capital, key aspects of mattering, predict significantly life satisfaction or wellness in the community. So this is to show that social policies do make a big difference in the sense of inclusion. Our first study consisted of 27 EU countries, and the second one entailed 41 OECD countries over a period of 10 years. So to measure social justice, we used the Bertelsmann Stiftung Institute definition in Germany, which consists of a number of policies and practices, including poverty prevention, access to education, labor market inclusion, social cohesion, lack of discrimination, etc. And this is part of the results of our study. Not surprisingly, the study found that countries with higher levels of social justice report higher levels of life satisfaction. Here we see the Nordic countries leading the pack, with the US, Australia, South Korea, and Spain in the middle, with Turkey at the bottom of both scales of social justice and life satisfaction. Here we see the relationship between social justice in the European Union and life satisfaction over a number of years, because this was based on a sequence of years from 2008 until 2017. Over a number of years, Denmark performed the best and Greece did quite poorly in terms of both justice and life satisfaction. Here's just one more image. Here we see the impact of the social justice index on social capital in the European Union. So here again, Nordic countries perform the best. Another way of stating the same results is to say that fairness improves wellness, both directly, as you can see from the blue arrow, going directly from fairness to wellness, and indirectly through adding value and feeling valued, the two key domains of mattering. Our work is in line with the famous studies conducted by Wilkinson and Pickett, in two UK-based epidemiologists, in which they explored how health and social problems vary across levels of income inequality. Their study found that the more economic egalitarian countries report higher levels of life expectancy, trust, social mobility, and lower levels of mental illness, teenage birth, and other problems. This graph shows that problems increase as inequality increases. In 1999, we were living in Canada. My family, that's where we met Jeff, and we worked together for many years. And according to this graph, our level of well-being was pretty good. We were kind of in the middle of the graph. Then in 2000, we moved to Australia, and we experienced a slight deterioration according to this graph. Then in 2003, we moved to the US, and according to this graph, we're definitely moving in the wrong direction, because as social as inequality increases, problems increase. But that's just my own personal story. But do let me finish with a quick summary. And my summary is this, that there is no wellness for people with psychiatric conditions or just anybody in society without a good level of fairness. So now I'm pleased to turn it over to Jeff, who will talk about housing first as an exemplar of transformative change for people with mental health problems. So thank you so much. I would love to hear from you. And now I'll stop sharing and turn it over to my great colleague, Jeff.
So good afternoon, Shalom. Like Isaac, I am very pleased to be with you here today to talk about the issues of community transformation in community mental health services. So I'm going to talk about transformative change to begin with, and then I'm going to move into, as Isaac said, housing first as an exemplar. There's many exemplars, but this is one that I have worked with for the past 10 or 15 years. I'll be discussing the evidence base and also how we could use that evidence base to influence policy. So, first of all, what is transformative change in community mental health? I think there are a number of principles that we rely on. The ecological perspective, where we look at the person in context. So we look at the family, the community, the whole of society. As Isaac noted, we also focus on empowerment and participation of individual citizens, not people with mental illness. We emphasize informal support and also peer support. Collaboration and partnerships with service and non-service organizations, and strengths recovery and wellness, not the drain approach, but the spec approach. And we pay attention to social justice, as Isaac has ably showed, because of its importance as a social determinant of mental health. Should you like to find more examples besides Housing First, there's a recent book that I've put together with my colleagues, Brett Clues from the United States and Jose Ornelas from Portugal, called Community Psychology and Community Mental Health. And there are a number of chapters written about little pockets of innovation in community mental health to emphasize transformative change. We can think about the transformative change paradigm ecologically. So at the level of services, an indicator might be widespread participation of consumers. That's people with lived experience. At the community level, we can think about community integration, which could be physically participating in the community, having a psychological sense of community, as well as social integration. And we can look at social conditions. Do the programs address income, housing, education, employment, some of these social justice determinants of mental health? And are there policies that support the reallocation of resources from traditional sources of support, like psychiatric hospitals, to these social determinants? There's a number of strategies that we can use. We can mandate and support consumer-run services. In the community, we can focus on the whole community, not just services. We can develop programs in the community that address the social determinants, and we can also advocate for progressive policies. So I'm going to talk now about Housing First as an exemplar. There's many different sorts of exemplars, but this is one that I think is pretty important because housing is a fundamental need for people who have experienced mental illness. So Housing First is aimed at assisting people with mental illness, addictions, and social needs who have long histories of homelessness It's not for everyone, but it is an important intervention for people with complex needs. It was started in New York City by a Canadian psychologist, Sam Sambaris. Some of the principles of Housing First are in line with the whole idea of transformative change. Housing is a human right, so we espouse a social justice, not a charity or a treatment model. People don't have to show preconditions of medication compliance or sobriety. There's no requirements for participation in treatment, and people are provided with immediate access to housing. No need to go through a lot of hoops or steps. Another principle is choice and control. We know that if we ask people who have been homeless, who have mental illness, where they want to live, they want their own place, their own apartment. More than 80% of people indicate in surveys across Europe and North America that they want their own place. So this is a focus on individualized consumer-directed services and consumer empowerment. Another principle is to separate housing and services so that the person is a tenant in normal housing. Recovery, which is a strengths or SPEC approach, focuses on wellness, not deficits, and community integration that I mentioned previously. Another important principle and approach within Housing First is harm reduction for people who have addictions. This is a little graph that shows, at least in North America, what typically happens with someone with mental illness. If they're homeless, they typically get placed in a shelter, then maybe into some kind of transitional housing or treatment, and then they get permanent housing. So we call this the staircase approach or the residential continuum. What's the essential feature is that it's treatment first and not housing first. People have to go through a series of steps. But in Housing First, what we do is we move people who are homeless directly into permanent housing. And in permanent housing, this model, when we try to transform the system, we do a reverse staircase. So we start off with permanent housing, scattered site, people live in many different places in the community. And only after the person has shown many difficulties and many tries to be able to live independently do we start to think about a single site setting or community-based treatment, or maybe even something longer term care. But the emphasis and what works for most people is clearly permanent housing with support. This is where we move from the least restrictive to the more restrictive setting. So what are the components of Housing First? It's very simple. There's housing and there's support. The housing is typically private market apartments. People get a rent subsidy so that they only pay 30% of their income for rent. They have their own leases. They have their own rights and responsibility as a tenant. The only requirement is that people must agree to a weekly home visit. They don't have to engage in treatment, but they have to have the visit to see as a check-in. There is also a strong commitment in Housing First programs and the providers to rehouse people who have to leave their setting for whatever reason. Some of the support services, there's really two main models: the assertive community treatment approach, which is now used around the world. You know, it consists of a multidisciplinary team. Crisis coverage exists 24/7. There's a very low staff to client ratio. And this is really for people with high needs, people with serious mental illness, typically some kind of diagnosis of a psychotic disorder or bipolar disorder, serious depression. For people whose needs are more moderate, we could use intensive case management, where the services aren't available around the clock, the case ratio is a little higher. And these are for people who don't have those kinds of diagnoses that I just mentioned, but still have a mental illness. So what's the evidence base? How well does this work? Well, I have to tell you, I was part of this really exciting study that we did called At Home Chez Soi in Canada. And the federal government allocated $110 million over 5 years to the Mental Health Commission of Canada for a demonstration project on the Pathways Housing First model. It's the biggest study of its ever conducted of its kind. And it was led by my colleague, Dr. Paula Gehring, who sadly passed away a few years after the end of the study. This is the logic model. So housing first leads to engagement and stable housing, connection with health and social services. And in a longer term, we believe that that should promote recovery, positive community function, community integration, quality of life. The SPEC approach. This is just a quick summary of the design. We had 5 cities going from Vancouver all the way to Moncton. If you've ever visited Canada, you'll know these are very diverse communities and size, ethnic composition. We wanted to investigate the effectiveness and the cost effectiveness of housing first. We did 2 fidelity assessments and implementation evaluations, and we tested the model with 2 levels of support. For high needs people receiving ACT and for moderate need people receiving intensive case management. They were compared with people randomly assigned to usual care, which is the typical services for people with mental illness or homelessness in the community. Sorry, I went too far. I'm going back. These are some of the participants. There are over 2,000 participants in housing first or usual treatment, mostly middle age. About a third women. About 22% identified as Indigenous people, largely from Winnipeg in the Western provinces. Typical time homeless in the person's lifetime was nearly 5 years. All had a serious mental illness. Many had other concurrent disorders, and many had other health problems. Across the 5 sites, these graphs, which may be a little small, the top line, well, the time on the x-axis is time, and on the y-axis is the percentage of time that they were stably housed. So the line at the top is always the housing first group, and the lower line is usual treatment group. Every city found that within 6 months, most people were able to be housed. Much greater, like 80% versus 30% typically, than those in usual treatment. This is the analysis for the ACT and the intensive case management. You can see that there's, for both groups, they were stably housed, and that it was able to be achieved in a 6-month time period. We also looked at some other variables, outcome measures, community functioning and quality of life. They showed similar trends of increasing positively at a greater rate for those in housing first than usual treatment. And this was a qualitative part, that study that I led, where we asked a subsample, about 200 people out of the 2,000, what kinds of changes they had experienced from baseline to 18 months. And they gave open-ended narrative interviews. They were interviewed, and we coded the kinds of changes that they talked about. Well, as you can see, the housing first group is about 60% said they talked about positive changes, compared to about 5% with negative changes. But if you look at usual treatment, it's quite a different picture. about 25 to 30% report positive changes, but the vast majority report mixed or negative changes. So it was very clear from talking to people that Housing First had made a big impact in terms of the changes they were able to make in their lives. The costs, we also did an economic analysis that depended on need level. So Housing First, for the high needs people with ACT, 96% of the costs were offset. Whereas with the case management, it was lower, about 46%. Still, overall though, the cost for a person with high needs for 1 year is about $6,000 and about $8,000 for those with moderate needs who receive case management. So not a terribly costly program. We also have from the Toronto site 6-year outcomes. They were one of the sites that followed the study sample for 6 years. So there's more than 300 people in this study. This is the ACT group. It's pretty interesting. After 3 years, the usual treatment group does make progress, but then it plateaus and they never catch up, even 6 years later, with the Housing First group. The same is true with case management, although the differences are narrow, more narrow, but the differences are still statistically significant. They never catch up after 6 years. This is not the only study. It was the largest study, but we worked with people in France because we had all of the measures translated into French, and there was a desire of the French government to do a similar study. They did a trial in 4 cities, all with people with serious mental illness. So they were all, those who were randomly assigned to Housing First got assertive community treatment. So you can see the 4 cities. The main findings were reduction of inpatient hospitalization, improved housing stability, improved quality of life, and their program saved money, about 217 euros per participant over the 2 years. So their economic analysis a little stronger than ours. I'm just going to end now with how the evidence base can be used to influence policy that matters to people, that adds value, gives value, and adds value. There's a distinction made in policy change about scaling out versus scaling up a program. So scaling out really means expanding a program to new settings, creating more of them, more Housing First. Whereas scaling up is a transformative change in the values, assumptions, and practices. Are we going to change the whole system? I'll give you a couple examples here. This is France, where based on the results of their trial that actually shows it saves money and is better for people, that program is being expanded to 20 new cities by 2022. I think there are around 16 new cities now, but this is something that the government has taken up, and you can see the map now that Housing First, which didn't exist 10 years ago, is now all over France. Another example of where Housing First has made an impact is in the US with a program called HUD-VASH. HUD-VASH is a program for veterans who have a high percentage of mental illness. And there was, during the Obama administration, a rollout of Housing First to serve veterans with mental illness who were homeless. So you can see how this program impacted people who were homeless in the HUD-VASH program. More people stably housed, and also, I'm sorry, that's the bottom line. More people stably housed, and also more people with chronic homelessness were positively impacted. They say in 73 US cities have ended veterans' homelessness. and that it's declined by about half, a little more than half. In Canada, we have the province of Alberta has led the way. They have decreased homelessness across the province. Edmonton has made a huge cut in their homeless population. And Medicine Hat, this little tiny community in Alberta, is actually the first community in Canada to reach what we call functional zero. They basically don't have homeless people. As soon as someone becomes homeless, they are housed. We also did, after At Home Chez Soi, a rollout and provided training and technical assistance to 20 communities. This is now taken up by the Canadian Alliance to End Homelessness. But as part of that, I did a study on it with colleagues, and in 6 communities, we created 14 new Housing First programs and enhanced and sustained others. We also made a change in federal policy. This is more scaling up Housing First. So federal government changed the rules around their allocation of funding. So the 10 largest communities were to allocate 65% of their funds to Housing First programs for people who are chronically or episodically homeless. And the remaining communities and Indigenous communities to allocate 40%. So some of the lessons about policy are that ideas matter. This whole idea of reframing homelessness from an individual deficit, the drain approach, to a social justice spec approach matters. Evidence matters. This whole focus on the different types of homelessness, like focusing on people with serious mental illness who have chronically or episodically homeless, that's had an impact on several countries. It's also important to involve people who have lived experience because they are experts because of their lived experience. The evaluation and randomized trials matter. We know from At Home in Canada and Chez Soi d'abord in France that these kinds of studies can have huge impacts. There's now an organization in France that is devoted totally to rolling out Housing First programs and other homelessness and interventions called DIAL. The political context, of course, is important. Like HUD-VASH expansion under Obama was a major win. Under Trump, something called Housing Fourth came in that went back to shelters, treatment, and sobriety. Thank goodness that is ending. And then timing matters. So there were instances in which the program at Home Chez Soi was conceived and sustained, and particular events that happened that facilitated that. I just now want to summarize. Individuals who experience mental illness and chronic homelessness can be successfully housed and live in their own homes. And I understand from talking with people in Israel that homelessness is not of the same magnitude that we have in North America or many European countries. If that's the case, great. I would say if you start to have more homeless people in Israel, don't build any shelters. Put the money into permanent supportive housing and Housing First. That's what'll work. Don't create an alternative drain system if that problem expands. It's a better use of public money than usual services, including shelters. High quality programs can be developed, policy can be changed, and Housing First can transform lives, services, systems, and policy. This is just the credits. These are some of the stakeholders with the At Home team. I think this has been made available to you. I express my gratitude to them at Health Canada. There's a lot of great information that's very user-friendly that you can access, videos, stories that are also included in the slide deck at the end, should you like to learn more. I thank you for your attention, And I look forward to any questions you might have.
Thank you so much thank you both of you for amazing lectures, very interesting. And you know, while you were talking, our Prime Minister and his Vice Prime Minister decided about a very stiff closure, which will begin on this Friday. Also in schools, and you know, much harder. And then we're supposed to see people suffering from job losing, and you know, for a very hard time taking all this on them. And I suppose that we will see a situation which is much harder.